Hi everyone, Jack Cush here on the convention floor at ACR 2024. Great meeting, even better when I run into great friend, great colleague, great mentor, Dr. Ted Pincus. Ted, how long have we known each other?
Oh, close to 40 years, I think.
Yeah. And he's still trying to teach me.
Yeah.
So we met on the
and you're teaching me, sir.
Well, that's the great thing about education, right? It's always the give and take.
Yep.
So we met on the poster floor yesterday. We were talking about a poster that Ted did today that was about estimating using a scale that you can use at practical use for patients that'll address a lot of things that we often don't address. Tell me kind of what you did.
Okay. So the impetus for all of this is that, as you know, even before Jack was a fellow, we were taught that we should do a formal joint count on all patients with rheumatoid arthritis. Most doctors don't do that, and there's a simple reason for that, I think, which is that a joint exam can be performed in 15 seconds that tells us whether we have 2, 12, or 22 swollen joints, and we can make a clinical decision. But in order to recognize whether we have 1 or 2 or 11 or 12 or 21 or 22, we have to spend an extra 60 to 90 seconds to write down 54 clicks or notations of a joint count. So we developed a 0 to 10 scale for inflammation, which we have found actually explains variation in the swollen joint count at our poster with a correlation of 0.7 versus a physician global of 0.37, so it's twice as likely to be found there. In addition, though, we've added a 0 to 10 global scale for the physician for damage and for patient distress. And it turns out today, and this has been found now in New York, Chicago, Nashville, and Sydney, Australia, that the scores for damage and patient distress are actually higher than inflammation. So, and unfortunately, the original 28 joint count included a score for deformity or limited motion, which has been dropped from the 28 joint count that's done in clinical care, because in clinical trials you don't include that. And so we only measure tenderness and swelling, but we should be aware of damage because we have now data of several RA cohorts where the median swollen joint count is 0, meaning that half the patients have no swollen joints, but the median pain score remains 4 to 5, and that's because of damaged joints and patient distress.
And that shows up on this scale, on these scales, right?
Yes, absolutely.
That's wonderful.
That's where the data come from, Jack.
Okay, so when you are taking these scales and putting them into practice, give me a practical application as to how it works. The good one was that one right there.
Yeah.
See, SJC swollen 0,
right?
And then, but these are abnormal. How is that going to affect what you do next?
Well, for example, I have seen a number of patients who've been tried on 5 or 6 biologicals who have a damage score of 5 and a patient distress score of 5. And these patients I have to think about, because all I'm really doing by giving them another medication is exposing them to side effects that isn't going to necessarily help them.
Right.
So I think we should recognize that, because that's true in all rheumatic diseases, as you know. Damage, once it occurs, and we published only around 1979 that 70% of patients with rheumatoid arthritis have erosions within the first 2 years of disease, and it's still the case that from first symptom to biological is 1.4 years in our clinic. Right. All the patients have damage, which proceeds on a biomechanical basis. So it's the real issue now is early treatment if we're going to meet the best capacities of our biological agents.
So I want to tell the audience that this man is responsible for the hack, the modified hack, the MD hack, Rapid 3, and at his center, when he was in Vanderbilt, his center developed the 28 joint count. So when Ted Pincus comes up with scales that you should be using to estimate what's going on, where can people start to use this, or where is this going to go?
I use it in all patient. I've been doing that for 20 years, and there's a very important point that I'd like to make to anybody who's listening to or watching this video, which is that it actually saves you time to have an MD hack. It saved me 3 minutes. I used to see 30 patients a day when I was very active, and most of the doctors could see 20 or 25 because I saved 3 minutes on average per patient. And the Rheumatric takes, which is the scales with the 10 clicks, takes about 20 seconds, whereas a 28 joint count takes 90 to 120 seconds, which we've published in the past. So you're actually saving time by using these tools, and having quantitative data about damage and patient distress really helps you a lot.
Do you know the poster number?
Poster number, I have it in my pocket.
Okay, you look it up and I'll close. So make sure you tune in for more videos and more content. Again, everything on video is going to show up in daily podcasts and in podcasts and whatnot. So hopefully you'll follow this poster and this report.
Here we are, poster
1077. Check it out. Thanks very much.